Critical Care and Trauma Masterclass. Primary Survey and Trauma Resuscitation. A systematic, life-saving approach to the initial 10 minutes of major trauma management following ATLS guidelines. Phase 1. The primary survey ABCDE identify and treat immediate life-threatening injuries before proceeding to definitive care. Airway and C-spine immobilization. Assess airway patency. Ask a direct question. Clear speech confirms airway, breathing, and adequate cerebral perfusion. Manual inline stabilization. Restrict C-spine motion immediately during airway manipulation. Use jaw thrust maneuver over chin lift. Definite V airway indications. GCS less than, equal to 8, severe facial fracture, expanding neck hematoma, or severe hypoxemia despite oxygenation. Emergency surgical airway. Perform needle or surgical crocothyroidotomy if oral endotracheal intubation fails. Breathing. Immediate chest threats. Tension pneumothorax. Distended neck veins, absent breath sounds, tracheal deviation. Immediate second ICS needle or fifth ICS finger decompression required before X-ray. Open pneumothorax. Sucking chest wound, greater than 2/3 tracheal diameter. Seal with 3-sided occlusive dressing to act as a filter valve, then insert chest tube. Massive hemothorax greater than 1,500 ml blood loss upon initial chest tube placement or greater than 200 ml per hour over 2 to 4 hours. Requires immediate thoracotomy considerations. Circulation and hemorrhage. Stop exsanguination first. Hemorrhage is the #1 cause of preventable trauma death. Apply direct pressure, arterial tourniquets, or pelvic binders immediately upon arrival. Establish 2 large bore, 14 to 16 gauge, IV lines or intraosseous, IO, access. Initiate permissive hypotension, target SBP 80 to 90 mm of mercury, until surgical source control is obtained. Disability and neurological status 8 is the GCS threshold for intubation. Rapid CNS assessment. Assess Glasgow Coma Scale, GCS, score, eye, verbal, motor responses, and pupil size, reactivity before administering neuromuscular blockers. Hypoxia and hypotension are the leading secondary systemic insults to the injured brain. Maintain PAU2 greater than 80 mm of mercury and SBP greater than 100 mm of mercury. Exposure and lethal triad. Hypothermia. Core temp less than 35 degrees Celsius impairs clotting cascade enzyme function. Maintain warm IV fluids, active warming blankets, and high room temperature. Metabolic acidosis. Tissue hypoperfusion increases serum lactate and base deficit. Worsens myocardial contractility and decreases coagulation efficiency. Coagulopathy. Trauma-induced coagulopathy, TIC, accelerated by hemodilution and hypothermia. Administer tranexamic acid, TXA, within 3 hours. Shock hemodynamic profiles. Hypovolemic shock, HR, tachycardia, 120 plus BPM, neurogenic shock, HR, bradycardia, normal, 55 BPM, neurogenic shock, extremities, warm and dry, vasodilation, hypovolemic shock, extremities, cold and clammy. Key clinical pearl. Neurogenic shock presents with hypotension plus paradoxical bradycardia due to loss of sympathetic tone above T6. Thoracic emergency differentiation. Clinical feature of tension pneumothorax breath sounds is absent unilaterally. Jugular veins is distended. Tracheal position is deviated contralaterally. Primary treatment is needle or finger decompression. Cardiac tamponade. Breath sounds is normal or equal. Jugular veins is distended or Beck's triad. Tracheal position is in the midline. Primary treatment is pericardiocentesis or window. Massive hemothorax. Breath sounds is a BSNT or dull percussion. Jugular veins is flat or hypovolemia. Tracheal position is midline or deviated and primary treatment is large bore chest tube. Secondary survey. Ample history. A. Allergies. Identify active environment and pharmacological allergies, latex, antibiotics. M. Medications. Screen immediately for anticoagulants, warfarin, DOACs, antiplatelets, and beta blockers. P. Past medical history, pregnancy. Evaluate baseline cardiac function and obstetric status in female trauma patients. L. Last meal. Establish full stomach aspiration risk prior to urgency surgical interventions. E. Events, environment. Detail energy mechanism, ejection, speed, blunt versus penetration. Massive transfusion protocol, MTP. 0-minute activation trigger MTP upon major hemorrhage or shock index more than 1.0. After 5 minutes transfuse 1 pack. Infuse 1:1 balanced ratio, PRBCs, FFP. Platelets. After 10 minutes transfuse TXA and calcium. Administer 1 gram TXA IV over 10 minutes plus 1 gram calcium chloride. After 30 minutes recheck laboratory monitor TEG, rotum, fibrinogen, more than 200, and arterial blood gas. For questions and discussion, please subscribe to the Critical Care and Trauma channel for high-yield medical lectures. Please like, share and hit the bell button and subscribe for more critical care and trauma content.